He had been a contractor for 38 years, built houses with his hands, climbed ladders into his 60s, never once thought of himself as someone who needed to worry about physical decline. Frank was 72 years old when his daughter brought him into my office, and the thing that had finally scared them both was not a heart attack, not a stroke, not a diagnosis of any kind. It was a chair, a standard dining room chair. Frank had started needing to use the armrest to stand up from it. Then he started avoiding chairs without armrests altogether. Then one morning he sat down on the edge of his bed, and it took him 3 attempts to get back up. His daughter watched from the doorway, and neither of them said anything, because they both understood what they were seeing, and neither of them had a word for it yet. Frank told me that was the moment he realized he might not always be able to live in his own home. He was not wrong to be afraid, but he was completely wrong about the cause. My name is Dr. Pablo. I am a board-certified geriatrician with 18 years of clinical experience, working exclusively with adults over 60, and the question of what determines physical independence in the later decades of life is one I have spent my entire career studying. Today I need to talk to you about a muscle. One specific muscle group that the majority of my patients have never once thought about, never once trained intentionally, and never once had a physician discuss with them in a routine appointment. A muscle that researchers now identify as one of the strongest predictors of whether an adult over 70 will maintain their independence or lose it. A muscle that begins declining silently, without pain, without obvious symptoms, often a full decade before the consequences become impossible to ignore. And a muscle that, with the right knowledge and the right approach, you can begin protecting and rebuilding starting this week. I want to keep something in tension for you as we move through this video, because I think the order in which you receive this information matters as much as the information itself. I am going to tell you which muscle I am talking about. I am going to tell you exactly what it does, what happens when it weakens, and what the research says about reversing that decline. But I want to build toward that reveal carefully, because if I give you the name before you understand the stakes, you will underestimate it. And underestimating it is exactly how millions of seniors end up where Frank was, sitting on the edge of a bed, unable to get up, wondering when everything got so hard. Let me start with something I do in my clinic that takes less than 10 seconds and tells me more about a patient's long-term health trajectory than almost any blood test I could order. I watch them walk, from the waiting room to the examination table. That is it. Walking speed and walking mechanics, the stability, the stride length, the symmetry of each step, constitute one of the most powerful aging biomarkers in all of geriatric medicine. A landmark study published in JAMA, tracking nearly 35,000 adults over 60 across multiple research sites, found that gait speed alone predicted survival rates, hospitalization risk, and functional independence with a statistical accuracy that rivaled far more invasive and expensive diagnostic tools. What the researchers were measuring, without most patients ever knowing it, was the downstream output of one specific muscle system. And when that system is failing, the walk tells you first. Now, before I go any further, I need to give you a number, because this number is the reason this conversation is urgent and not merely interesting. After the age of 60, adults who do not engage in targeted resistance training lose between 3 and 5% of their muscle mass every single year. That process has a clinical name, sarcopenia, and it is not an inevitable consequence of aging in the way that most people assume. It is a condition, a diagnosable, measurable, and in many cases reversible condition that the World Health Organization formally recognized in 2016. And that the American College of Sports Medicine now considers one of the primary modifiable risk factors for loss of independence in older adults. But here is what the general conversation about sarcopenia almost always misses. Muscle loss does not happen evenly across the body. It follows a pattern, and the muscle group at the center of today's conversation is among the first and fastest to go, and the one whose loss cascades into the widest range of consequences across your entire physical system. There is a test I want you to try right now, if you are able to do so safely. It is called the 30-second chair stand test, and it is one of the most clinically validated functional assessments in geriatric medicine. Take a standard chair without armrests, or sit toward the front of a chair and cross your arms over your chest so you are not using them. Set a timer for 30 seconds. Stand up completely, sit back down, and count how many full repetitions you can complete. If you are between 60 and 64 years old, the normative reference range established by research published in the Journal of Aging and Physical Activity is 14 to 19 repetitions for women and 14 to 19 for men. If you are between 70 and 74, the expected range drops to 12 to 17. If you completed fewer than 10 repetitions regardless of your age, or if you found yourself instinctively reaching for arm rests before you even began, that result is a clinical signal, not a verdict, not a life sentence, a signal. And signals, in medicine, exist to be acted upon. What that test is measuring, what every stumble, every slow rise from a seated position, every moment of hesitation at the top of a staircase is measuring, is the functional output of the gluteal muscle complex. The gluteus maximus, gluteus medius, and gluteus minimus working together as the primary engine of upright human movement. I said I would delay the reveal, and I have given you enough context now to understand why this reveal matters so much more than the name itself. The glutes, a muscle group most adults associate with aesthetics, with athletics, with everything except medical necessity, are the single most important muscle system for physical independence in adults over 60. They are the forgotten muscle, and they are almost certainly weaker in your body right now than you realize. Here is why this happens and why it happens so quietly. The gluteal muscles are what exercise physiologists call a posterior chain anchor, meaning they are the foundation from which virtually all lower body and core movement originates. When you stand up from a chair, your glutes fire first. When you climb a stair, your glutes absorb and generate the force that makes the movement possible. When you walk, your glutes, specifically the gluteus medius, stabilize your pelvis with every single step, preventing the lateral sway that leads to stumbling, tripping, and falls. And when you are simply standing still, your glutes are working constantly to maintain the postural alignment that keeps your spine, your hips, your knees, and your ankles in their proper structural relationship. Now here is the critical failure point that makes this muscle group uniquely vulnerable in the modern senior population. The glutes are inhibited, neurologically switched off, by prolonged sitting. This phenomenon is so well documented in sports medicine and physical therapy literature that it has its own informal clinical name, gluteal amnesia. When you sit for extended periods, the hip flexors at the front of the body shorten and tighten. The nervous system, in response, begins to downregulate the activation signal to the opposing glutes. Over months and years of sedentary behavior, and sedentary behavior increases dramatically in adults after retirement, the glutes do not simply weaken from disuse. They partially forget how to fire correctly, even when you need them. The movement patterns that should automatically recruit your gluteal muscles instead recruit compensatory muscles, the lower back, the quadriceps, the hip flexors themselves, leading to the chronic low back pain, the knee discomfort, and the hip stiffness that so many of my patients describe as simply getting older. It is not simply getting older. It is a specific, identifiable, addressable neuromuscular failure pattern. A study published in the Journal of Orthopedic and Sports Physical Therapy measured gluteal activation levels in adults over 65 during standard daily movements and found that a significant proportion demonstrated what researchers classified as inhibited gluteal firing patterns, meaning the muscle was present, it had not completely atrophied, but the neurological recruitment signal was so diminished that the muscle was contributing a fraction of the force it should have been generating. These were not sedentary, unwell patients. These were community-dwelling older adults, many of whom considered themselves reasonably active. The inhibition had developed gradually, invisibly, beneath the threshold of their awareness. Margaret was 66 years old, retired elementary school teacher, grandmother of 5, a woman who walked her neighborhood every single morning for 45 minutes and considered herself in good health. She came to me because of what she described as mysterious back pain that no one had been able to explain after 2 years of chiropractic care and a course of physical therapy focused entirely on her lumbar spine. When I assessed her gluteal activation during a simple single-leg stance test, standing on one leg for 30 seconds, which I want you to also try carefully right now if you are able, her gluteus medius on the left side showed almost no measurable activation. Her pelvis dropped visibly on the right side the moment she lifted her right foot. That pelvic drop, called a Trendelenburg sign in clinical practice, is a direct marker of gluteus medius insufficiency. It was the cause of her back pain. It had been the cause all along. Every step she took on her morning walk was being completed with a compromised stabilization system, placing asymmetric load on her lumbar spine with every single stride. We redirected her rehabilitation entirely toward gluteal activation and strengthening. Her back pain resolved within 11 weeks. She has not returned to the chiropractor since. Now I want to talk about falls, because this is where the conversation moves from discomfort and back pain into territory that I need you to take with complete seriousness, because the statistics behind what I am about to tell you are among the most sobering in all of geriatric medicine. The Centers for Disease Control and Prevention reports that 1 in 4 adults over 65 experiences a fall each year in the United States. Falls are the leading cause of both fatal and non-fatal injuries in older adults. More than 3 million seniors are treated in emergency departments annually for fall-related injuries. And here is the number that stops my patients cold when I share it. According to data published by the American Academy of Orthopedic Surgeons, approximately 20% of seniors who suffer a hip fracture, one of the most common serious fall injuries, die within 12 months of that fracture. Not from the fracture itself in most cases, but from the cascade of complications that follow: immobility, pneumonia, blood clots, the physiological devastation of prolonged hospitalization in an aging body. A fall is not an accident in the way most people use that word. A fall is the end point of a physical decline process that was building for years. And the gluteus medius, the stabilizing component of the muscle group we are discussing today, is the primary dynamic stabilizer of the pelvis during walking, the structure most responsible for preventing the lateral instability that turns an ordinary moment of imbalance into a fall. Research published in the journal Gait and Posture, examining fall history and muscle function in adults over 70, found that hip abductor weakness in the muscles responsible for lateral hip stabilization, with the gluteus medius as the primary contributor, was present in a significantly higher proportion of fallers compared to non-fallers, even after controlling for age, medication use, and overall activity level. This was not a marginal association. The researchers described hip abductor weakness as one of the most consistently identified modifiable risk factors for fall incidents in community-dwelling older adults. Modifiable. That word matters, because it means this is not something you simply accept. It is something you address. I want to pause here for a moment and ask you something directly. If you are over 60 and you are watching this, if any of what I have described today has felt personally familiar, whether it is the chair test result, the back pain, the balance hesitation, or simply the quiet awareness that your body is not moving the way it used to, I want to hear from you. Write your age and where in the world you are watching from in the comments below. I read these, and more importantly, I want you to know that what you are experiencing is not unique to you. It is not your fault. And it is not the permanent condition that it may feel like right now. Tell me where you are. You are in better company than you know. Now I need to tell you about the connection that I promised you at the beginning of this video, the one that elevates this conversation beyond muscle strength and fall prevention into something that I believe will genuinely change the way you think about physical activity for the rest of your life. The relationship between skeletal muscle, particularly large lower body muscle groups like the glutes, and brain health is one of the most rapidly developing areas in all of neuroscience. And what researchers are finding is extraordinary in its implications for every adult over 60 who wants to protect not just their physical independence, but their cognitive longevity. Here is the mechanism. Skeletal muscle is not simply a mechanical tissue. It is an endocrine organ, meaning it produces and secretes biologically active compounds that travel through the bloodstream and act on distant tissues, including the brain. These compounds are called myokines, and their discovery has fundamentally altered the scientific understanding of why physical activity protects the aging brain. When large muscle groups contract, when they are loaded, challenged, and activated, they release a specific myokine called irisin. And irisin, according to research published in the journal Nature Medicine, crosses the blood-brain barrier and directly stimulates the production of a protein called brain-derived neurotrophic factor, or BDNF. BDNF is what neuroscientists sometimes call miracle grow for the brain. It promotes the growth of new neurons, strengthens synaptic connections, protects existing brain cells from age-related degeneration, and has been specifically associated with reduced risk of Alzheimer's disease and other neurodegenerative conditions. The larger the muscle group generating the contraction, the greater the myokine release. And the gluteal complex, the largest muscle group in the human body, is therefore one of the most powerful BDNF stimulating systems available to the aging brain. When your glutes are strong, active, and firing correctly, they are not just holding you upright. They are producing a neurochemical signal that travels to your brain and tells it to stay healthy, stay plastic, stay resilient. When your glutes are weak, inhibited, and underused, that signal diminishes. And the brain, which depends on the body's movement for a significant portion of its maintenance chemistry, begins to operate on a reduced biological budget. A landmark study from the University of British Columbia, published in the British Journal of Sports Medicine, assigned sedentary older women to either a resistance training program targeting lower body muscle groups or a stretching and toning program, and measured hippocampal volume, the size of the brain's primary memory center, over 12 months. The resistance training group showed measurable increases in hippocampal volume. The stretching group showed no such change. The researchers concluded that resistance exercise targeting large lower body muscle groups produced direct, measurable neuroprotective effects on the aging brain. This was not a small pilot study. This was a rigorously controlled, randomized trial whose findings have been replicated in subsequent research at institutions including Harvard Medical School and the Mayo Clinic. This is the connection I needed you to understand before I gave you the protocol, because I do not want you to do what I am about to describe because you want stronger legs. I want you to do it because you want to keep your mind. I want you to do it because you understand now that the forgotten muscle sitting at the foundation of your body is simultaneously the foundation of your brain's biological support system. That changes everything about the motivation. Thomas was 70 years old, retired university librarian, a gentle and intellectually rigorous man who had spent his career surrounded by knowledge and who came to me deeply frightened by what he described as increasing mental fog, difficulty concentrating, and a word-finding difficulty that had been worsening over 18 months. His neurological workup was reassuring, no evidence of significant pathological change, but his physical assessment told a clear story. Profound gluteal inhibition bilaterally, a chair stand test result of 8 repetitions, and a gait analysis showing the compensatory shuffle pattern I associate with advanced posterior chain weakness. Thomas had been almost entirely sedentary for 4 years following his retirement, spending the majority of each day reading in a chair he described as exceptionally comfortable. We built him a progressive resistance protocol targeting his gluteal complex specifically, beginning with activation exercises and advancing to loaded movements over 16 weeks. At his 6-month follow-up, his chair stand result had increased to 16 repetitions. His gait had normalized, and Thomas told me, unprompted, that the mental fog had lifted, that he felt sharper than he had in years, that words were coming back to him. I was not surprised. The research had told me to expect exactly that. So let me now give you the practical protocol, specific, sequenced, and designed for adults over 60 who may be starting from a place of significant gluteal inhibition. I want to be clear about something before I walk you through this. The goal in the beginning is not strength. The goal is reactivation, waking the muscle back up, re-establishing the neurological connection between your brain and a muscle group that years of sitting may have partially silenced. Strength comes after activation. Attempting to load a muscle that is not yet firing correctly is one of the most common rehabilitation errors I see, and it is the reason so many seniors begin exercise programs, feel increased pain and instability, and conclude that exercise is making them worse. Begin every single day. Morning is ideal, within 30 minutes of getting out of bed, with what physical therapists call a glute activation sequence. Start lying on your back with your knees bent, feet flat on the floor. Perform a glute bridge. Press through your heels, squeeze your glutes deliberately and consciously before you lift, and raise your hips until your body forms a straight line from shoulders to knees. Hold for 3 seconds at the top. Lower slowly. 10 repetitions. The key is the deliberate pre-contraction squeeze before the movement begins. This is what begins to re-establish the neurological firing pattern. Without that conscious squeeze, larger compensatory muscles will simply take over and the glutes will remain passengers. After your bridges, move to a clamshell exercise. Lie on your side with knees bent at approximately 45 degrees, feet together. Keeping your feet touching, Rotate your top knee upward like a clamshell opening, as far as you can go without your pelvis rolling backward. This isolates the gluteus medius specifically, the stabilizing muscle most responsible for fall prevention. 15 repetitions on each side. If you feel this exercise primarily in your hip flexors or outer thigh, rather than deep in the side of your glute, you are compensating. Slow down, reduce the range of motion, and focus the contraction. 3 times per week, not daily, because muscle tissue requires recovery time to adapt and strengthen. Add a loaded movement. The most clinically appropriate and accessible option for most adults over 60 is the sit-to-stand exercise, performed slowly and with intention. Using a chair of standard height, stand up without using your hands. Pause for 2 full seconds at the top while consciously squeezing your glutes. Then lower yourself back down slowly, taking 4 full seconds on the descent. The slow descent, called an eccentric contraction, is where the majority of strength adaptation occurs and is the most commonly skipped component when people perform this movement casually. 3 sets of 10 repetitions, 3 times per week. This single exercise, performed correctly and consistently, is what moved Frank's chair stand test from 9 repetitions to 17 over the course of 5 months. It is what gave him back the ability to get up from any chair, in any room, without planning his exit before he sat down. As your strength and activation improve over 6 to 8 weeks, add a single leg balance component to your daily practice. Stand behind a sturdy chair, hold lightly for safety, and lift 1 foot 2 inches off the floor. Hold for 20 seconds. Switch sides. This directly trains the gluteus medius in its stabilization function, the function that prevents falls, and the neurological adaptation it produces transfers directly into safer, more stable walking. Research from the journal Age and Aging found that balance training programs targeting hip stabilizer activation in adults over 65 reduced fall incidence by up to 34% over a 12-month period. 34%. From 20 seconds of standing on one leg, performed daily. Here is what I want to leave you with today. Frank, the contractor who came to me unable to rise from a dining room chair without bracing himself on the armrests, completed his 5-month glute reactivation and strengthening program. He did not do it in a gym. He did not work with a personal trainer. He did the activation sequence every morning before breakfast and the sit-to-stand protocol 3 times a week in his living room while the news played in the background. At his 6-month follow-up appointment, he walked from my waiting room to the examination table, and I watched every step. The shuffle was gone. The hesitation was gone. The lateral instability that had been quietly telegraphing his risk with every stride was gone. He sat down in the chair across from my desk without looking for armrests. And when it was time to leave, he stood up in one clean, unhesitating movement. He looked at me and said, "I forgot what it felt like to just get up." I told him that was exactly the point. The muscle had not forgotten him. He had simply stopped reminding it that it was needed. You are not too old for this. The research does not support that conclusion, and neither does 18 years of watching patients rebuild what they thought was permanently lost. The forgotten muscle is forgotten only because nobody told you it needed your attention. Now you know. And knowing, in medicine as in life, is where everything begins. If this video gave you something useful today, if something I said changed the way you understand your own body and what it is asking of you, share it with someone you care about. There are people in your life right now who are avoiding chairs, avoiding stairs, avoiding the question of how much longer they can manage on their own, and they do not yet know that the answer may come down to a muscle nobody warned them about. Send them this video. And if you are not yet part of this community, subscribe, because every week I bring you the kind of honest, evidence-based, clinically grounded information that your health deserves, and that a 15-minute doctor's appointment will almost never have time to give you.